I think one of the things that I've seen from Spark is the amount of passion and drive from clinicians and technologists to really try and improve things for those who we deliver healthcare to.
Spark feels like the culmination of years and years and years and years of dialogue around better connected healthcare.
I think it's really the community and how everyone has been brought together driving towards a common goal.
It is such an amazing initiative, something that we've wanted to do as an industry for many years, but we needed someone to get us organised.
I think what makes us want to be involved is it's a community that is working together to improve interoperability for Australians.
Finally, 23 years later, with a whole lot of energy and effort, we're now here. And the number one thing is let's get data quality right first and foremost, and then we can start to exchange that data.
We're not doing the countdown again. I had it on loop for the lunch break. It's the final session of the Sparked Symposium 2025. My name is Peter Birch. I'm your host for this session today. Drop a message in the chat if you're back from our short break, because we've got a bumper session to see us out as the rest of the world rises. We've covered everything so far across the Sparked digital health and interoperability ecosystem, looking at a high level and getting inspiration from other parts of the world, starting to break that down, what that looks like at a jurisdictional level, and then seeing some great demonstrations of really what this looks like in action. And we're really just getting started. But the next session that we are diving into right now is titled Standards Here, Standards There, and Standards Everywhere. We've got a few different speakers which you'll see on the agenda. Without further ado, let's dive into it. All right, now joining us for this next session, I've got the one, the only, the Grahame Grieve. Great to have you here for this session. It would not be any kind of Sparked event without your gracious presence. So great to see you today, Grahame.
Hey, Peter, it's great to be here with you, but don't get carried away there.
I would expect only that answer from you, Grahame. So thank you. Look, I'm going to pass the virtual stage over to you because I would love to hear your thoughts, reflections. You've got the floor for 10 minutes, and take it away.
Thanks, everyone. I'm here in Estonia today. I'm sort of doing a tour across Europe, talking to HL7 affiliates and government agencies about their challenges and how we can, move things forward. And it actually turns out that everybody has the same challenges, the same things that are, like we've got our current investments in usually older standards, although sometimes they're just older versions of FHIR now. We've got our functionality gap between where we are and where we want to be. We've got our local resources. We've got challenges from expectations being imposed from outside the country, either internationally or in Europe regionally, with the European health data space. And I think from looking at what's happening here in Europe, we should be paying more attention than we have been to the European health data space. And maybe that's just me. Maybe I should be. But it's certainly a pretty interesting policy area, and they're having a lot of debates about the interaction between privacy and security, which really matter here in Europe, and data availability, and how regional differences in policy around handling information interact with a shared health space. So it's pretty interesting work. Then those countries have challenges around their political guidance and the challenges, and what are they trying to achieve, and how does interoperability fit into a wider standards agenda around expectations for system behavior and data processing. And those really sound very familiar to Australians, right? And in fact, they're the key that led to us doing Sparked. And so, from my perspective, one of the things I can talk about is how Sparked is such a great community initiative, a way to manage the relationship between those various tensions and capture enthusiasm in the community. And I was pleased to be able to say finally, as compared to where we were a few years ago, that we are actually doing that. So I think that there's plenty for us to focus on and to be happy about where we are while we take on what are going to be key challenges. I visited the WHO, and one thing that stood out from the WHO is I'm going back to Geneva for a meeting in July because I love travel, to talk about digital wallets and operating system support for digital wallets. There's a meeting that's not only about health, it's about digital wallets per se, but the WHO is leading the health track, and it's going to be all about patient summaries, IPS, in your digital wallet, whether that's phones or tablets or computers. And a big theme of the month that I'm here in Europe for is really collaboration with other SDOs. I mean, most of you have probably heard that we have an openEHR meeting next week. There's a lot of focus on OBOP and how to scale data analytics and data processing. And those challenges are just growing for everybody. But what's really clear is that we need healthy communities that can operate with fidelity and high trust communities, but have plenty of enthusiasm and the ability to move forward and get things done. And for Sparked, that is always been the focus, and I think that the way that we've set up Sparked and the governance work that HL7 Australia is doing, and the enthusiasm of and tireless work of people like Kate, really stands us in good stead. Our challenge is to capture that, to grow in maturity, and focus on achievements and not getting distracted from achievements. And actually, that's the kind of a challenge that's come up for me in multiple countries, which is what is the most effective way? What is the most efficient way for us to land what IHG call the final mile, which is to take the specifications and the enthusiasm from the community and connect that to the sponsors, the consumer institutions that wish for implementations of those standards that are proven, certified to work. What is the path towards making those certification practical, manageable, and deliverable? How do you keep the costs down? How do you deliver something that's meaningful? There's a joke about IHG, which is interoperability in hotels and exhibitions. Although I think that's my life, is presentations from hotels and exhibitions, eh? But what is the process, and how do you manage that? And there's challenges for us here. Some of you might remember how this went when we tried this with the My Health Record. It wasn't a scintillating process. And so how can we have one? I think that we need to think about that across the board as participants, from a governance viewpoint or the sponsor viewpoint or the collaborator, who's undergoing certification. What is it that we want out of the process to deliver the certainty that we all need? I think that's a challenge in front of HL7 Australia, in front of the HL7 community more generally. We do live in uncertain times, some of you may have noticed, for non-governmental organisations, and so we have a number of challenges at the governance community management level. But at least for the moment, our work is ahead of us, and I'm certainly happy to point people around the world at the Sparked process and the way that we manage the community and the way that we excite and create passion within the community. For all of you listening, thanks very much for being part of it. In some world, I'll figure out how to get the glasses, light in my glasses thing figured. But in the meantime, thanks for being part of what we're doing. And let's go.
Let's go indeed. No, look, Grahame, I appreciate that kind of scene setting there, and we will bring you back on because all of the presenters and speakers in this run will come onto a bit of a panel at the end too. So I'm going to get you to sit tight for a moment there while we move on to have a chat with Rachel. Thanks so much. I realise it's probably super early in the morning for all of the participants, so loud, bangy music maybe that's a good thing that they need in order to be able to. But who needs excitement and external influences when you can speak about interoperability? And none other than Rachel Dunscombe is joining us for this next session. Rachel, thank you so much for joining.
Great to be here. And that music, waking me up with caffeine, definitely.
Get up in there. So what I'm going to do is just bring up your slides and I'll let you take it away, and I can just drive those slides for you. Just let me know when you need to.
Absolutely. I wasn't sure whether to do slides or not, but I thought as an aid memoir at this time of the morning, probably good. So on to the next one. Yeah. Fantastic. It's really amazing to be with you. What is happening at Sparked is just world leading. So congratulations, everyone. I think for me, this is the most heartening thing I can see globally in digital healthcare. So, delighted to be here. Right, on to the next slide. So I'm just taking a look at why we're doing this. And actually, I was with Grahame last week when we were talking about why we do what we do. And data is basically the new infrastructure for healthcare in the coming decades. So to enable us to deliver healthcare in people's, mobile world, in, communities, it's basically the virtual walls of the hospital, the virtual walls of the health system. And data is becoming a capital asset. And what I mean by that is actually accounting rules in the UK have changed. We can now capitalize data and IP around it in the way that we can hospital walls, because it is a long-term asset, right? So if you take a patient, their data could have value for 100 years and beyond if they gift it to their family as part of their health record. And so our focus here on data and interoperating that data is absolutely key for the future. Every industry is now becoming data-driven. And why we're doing this is because data is the key to making health systems sustainable. So data is a capital asset. Data is part of the infrastructure for the future is key. And actually, I've been doing some work with London School of Economics around the effects that data have on healthcare, and it's really super interesting. If you get data that is clean, codified, real time, in the right place at the right time, you increase equity. That's a really nice side effect. So, I think that we've all got a shared mission here to improve care, to improve equity, to improve outcomes, but to create sustainable health systems for the future. And Sparked is, directly contributing towards that. Next slide. So I'm going to dwell a bit on openEHR and also the work we're doing with Grahame and the HL7 crew on FHIR. So why is openEHR, important? So I'm a recovering CIO, I've been there, I've done it, I've used all of these standards. And for me, openEHR is really important. I think I found its importance when I started to work on AI back in 2017. And I realized that simple concepts like observations or whatever else were scattered across my different systems and multiple times in any one health record. Bringing them together and semantically harmonizing them was the only way that we could do things like risk stratification across pathways, which I was doing for AKI, sepsis, delirium, dementia, all sorts of things. So it's, a computable standard that is semantically harmonized, and it's rich. It could deal with all of the use cases that we needed. And I kind of think of it as the clinical brain, that you've got data, meaning, and integrity over time. Next slide. So, FHIR, as Grahame knows, I've always been a huge fan of both standards, and part of my quest was to understand how the standards could work better together. So for me, FHIR as a standard was the interchange. It was about speed to value, rapid implementation. The accelerators I was running absolutely needed FHIR. It was standardized data access. So I kind of think of this as the universal adapter, connecting systems, applications, enabling an ecosystem of solutions. And that's absolutely key, because if we want to keep, a standardized data layer, we want the applications to become evergreen around it. So to be able to iterate and not build in technical debt for the future, not have to do massive lifts forward within health systems. Next slide. So clinical governance. openEHR really is different to other standards in many ways, because it has this clinical governance. And what does that build in? It's got safety and quality. So, with clinicians inputting, we're making sure that we have safety and quality, clinical validity, the standardization that is needed. We've got a controlled evolution, accountability, and fitness for purpose. And that gives us longevity. So there's consistency across time, and it avoids the sort of data lock-in that I've certainly had in the past from certain systems. But the ultimate outcome is trustworthy, reliable clinical information for better decision-making and robust interoperability, as well as being fit for purpose for the future for the likes of clinical AI. Next slide. And the co-design. The co-design is really important. So within openEHR, we have, clinicians, technologists, and others sort of co-designing and moving things forward. And, increasingly, we also have the likes of the patient voice in there as well. So how does that work? Well, it makes things clinically relevant. It improves the usability by having the different perspectives. It enhances safety. So unwarranted variation in data causes unwarranted variation in care, which causes, obviously, unwarranted outcomes. So we have to, have an eye on how we operate safely. Workflow alignment. So reducing clinicians' burdens by ensuring the technology is fit for, their practice. It increases adoption and ownership, because when clinicians are vested and are part of the process, as they are with Sparked, it fosters buy-in, right? So this community model ensures that everyone is a stakeholder. And then iterative improvement, giving, people a voice to actually input and improve. So again, the ultimate outcome here is effective user-centered healthcare information solutions that really support clinical practice and improve patient care. So that's why co-design, within a community is important. Next slide. So pivotal movements, converge or collide. Where we're, collaborating with HL7, we're actually looking at a number of different initiatives, and actually very much inspired by what you've done at Sparked. And, we've got Brett and Heather with us next week, who'll be talking at our event. So we're going to be in Amsterdam. We've got Grahame with us as well, which is going to be absolutely fantastic. Kate too. And it's, around about 50 leaders from both communities who are going to be looking at 13 areas we've identified and kind of prioritizing, saying, where are we going to get the best value to improve healthcare? So this collaboration matters because we need the best of both worlds. And for me, as a former CIO, I want things to work better together to get more value for health systems. So got the strengths of HL7 FHIR, that agile data exchange, the ecosystem approach where we can, make the data interoperable. And we've got obviously openEHR, which can, create that consistent semantic layer. So together we can provide this powerful, future-proof digital health ecosystem. It's data for life. exchange for care. So that's kind of the way I think of it. Next slide. Yeah, so, the last slide, we had that kind of converge or collide, graphic. Here we've got this is what it could be. It's the giant hug. I know Grahame likes this kind of graphic. What can we achieve together? Well, can we get true semantic interoperability between, our standards and the wider ecosystem? Can we future-proof architecture? For me, as a former CIO, again, to actually be able to have an architecture that is future-proofed and be able to spend more time as a CIO on delivering new models of care, delivering the future as opposed to trying to, wrangle with feral data, that would be fantastic. Can we enhance data quality? That's something, as we said, we need for AI, we need for the future. Can we innovate and support, the future ecosystem of solutions that need to fit around the patient record and the system record? And can we, explore the benefits of clinical co-design and what that can offer for all of us? So for me, openEHR, that clinical detail FHIR, the standardized access equals a clinically sound, interoperable and future-proof digital health landscape. So I'm very much looking forward to that event. And thank you for everyone that's going to be with us. We'll certainly be reporting back to you guys at Sparked. But my hope is that we make this easier to use for health systems and we get that sort of speed to value, but a sound architectural basis for the future. Next slide. So all in all, thank you so much for, letting me share what we're doing. Just to echo back what Grahame's saying, Europe is doing some really exciting things. They're looking to you at Sparked as well. I think it's really important that we keep this, continued dialogue up, but I'm looking forward to the discussion a bit later.
Amazing. Thank you, Rachel. It's great to hear some of that progress and yeah, inspiring and kind of cool to hear about some of that almost inspiration from some of the momentum on the Sparked side to see what can be replicated in other parts of the world too. So I'll be bringing you back onto the screen shortly once we've heard from a few other international digital health standard leaders. Thank you so much. It's rare to have, like in one kind of digital event, pull together these types of caliber of speakers. It's super grateful to be joined by Charles Gutteridge. I'll bring you up on the screen. G'day, Charles. It's great to have you here from SNOMED International, another important, critical part to this whole discussion. And thank you for joining. It's what's probably an unreasonable hour at your end as well. So I will bring up your slides to make sure that's all working appropriately. And we will remove the previous ones and bring yours on like this. There we go. And you should be able to drive those as you brought them up, but I can jump in if needed. Over to you, Charles.
Thank you very much, Pete, and thank you for welcoming me so nicely. Look, I'm an old person, and I've lived through, I think, a lifetime where I started out in the early 1970s without any computers in health. And I'm ending my career with an amazing access to the application of human intelligence to medical care. And I think we are really into a revolution that is now, 60 years in its making, where individual humans have an extraordinary ability and access to systems that can do healthcare maintenance for themselves. My secret hope, obviously, speaking as a clinician, that I will continue to be involved, to be an advisor, a guide of how you get through those things and how you manipulate and deal with your health using data yourself. And the role of the doctor doesn't just disappear because the machine can do it. The starting point for all of this, and this is what this slide is about, which is all of you will look at this slide and interpret it in different ways. So, for example, Kim Drewer might say, well, the Scarlet, core blimey, Kim, is something quite different to my concept, which is computable biomedical knowledge. Baroness ontology is a sly reference to my quote above, which is Baroness Orsi's description of the Scarlet Pimpernel in the book by the same name. All of you will put that together in different ways as a form of medical history. And because everybody does it differently, and because turning that into structured data is so hard, sometimes it's easy to feel that progress is slow and we're not really making a fast process across the globe and finding ways of helping that data literacy that other people were talking about when I first joined this group about half an hour ago. But I would disagree. I think we're making fast progress, and you won't be surprised to hear me say, and it's because of the glue that SNOMED puts into the system. So let me talk a little bit about where we are. So I think it is fair to say that at the moment we have extraordinary systems. Here's an example of some little views of the NHS app and the things that appear in the NHS app. So I can access NHS services. Appointments appear in that. My problem list appears as my GP health record. I can see prescriptions and so on. I can see letters. I can see summaries, and I can see results and so on. I think it's an astonishing tool, particularly when I sort of compare it to my lifetime experience of care. The problem, of course, is the data are not yet interoperable and not research ready. So what can we do about that? Well, a key role here is the terminology. And here I have a little map of what SNOMED is doing across the globe in helping us all to have content that is usable in FHIR, in openEHR, and so on. Mapping tools from the words that I use and think about to represent the clinical history with the patient sitting next to me. So there are mapping tools, there are reference sets, and so on. And I'm just going to take you through one or two of the examples. I think the first thing to say is that this is now a global phenomenon. So there are different editions of SNOMED in different languages. There are editions which are part of a national system. There are editions which are international and used across the globe. And you're all familiar with that. We're now up to 52 member countries. And fantastically, the last member country is Mongolia. So from starting with a core number of founding members, of which Australia was one in 2007, we now have 52 member countries, all contributing to that content, contributing to the dialogue that is so important to making healthcare work. And the amazing thing, of course, is when you encode language into numbers, it is possible to translate. So here's a Spanish version of something which made me laugh. So buceador is the Spanish for diver. We have a diving term as an employment in SNOMED. And the story about henyeos are about female South Korean divers on the island of Jeju who are self-selecting themselves over generations of diving to protect themselves from hypertension and lung disease because they're acquiring or self-selecting mutations in their DNA, which protects them from the bends, from preeclampsia and so on. And it's just a great example of how we can use a spectrum of data across the world. Our machines can translate all of that into different languages. There isn't yet a South Korean version of SNOMED, so I couldn't show you the South Korean version, but I'll show you the Spanish one instead. This slide begins to describe those things which I think were, in a sense, peripheral to health because the focus is always on doctors, doctors, doctors. And actually, the drive for really great health comes from great behavior, keeping thin, getting good nutrition, and so on. And it's so cool now that SNOMED as your core terminology, for example, has included the nutrition care process terminology as a reference set. There are some example codes for you to use right now in your version of SNOMED, either your local country edition or the international edition, and you can build a knowledge bank of what people are eating, what they're doing to themselves, and use those data with their genomes, with their history and so on, to make for great health in the future. The same thing applies to pathology testing. So our collaboration with LOINC is now a real thing. Here's an extract just showing how we can use both the knowledge in LOINC and the knowledge in SNOMED to add real value to an EHR because the data are aligned and perfect for use. And then finally, in this little bit, I think, our medical world should, I think, lower our heads slightly in shame and say, actually, probably the best users of EHRs, the best users of data capture are our nursing colleagues. And it is, again, with great pleasure and pride that I say we now have an astonishing range of the terms from the international collaboration community on nursing practice and process. And here are some codes as examples, which are in SNOMED and can be used by nurses to record their thoughts, their ideas about a patient's diagnosis and their progress through care, and record those and use those in the same way that I just described for research and so on. So let me bring you home to London, which of course is the best city in the world. It's a lot better than Amsterdam and Paris. It may not be quite as great as Sydney, but it's really cool. And Barts is in the east part of London and has built a data platform which is set out here. I'm not going to take you through this, but just to say that this is a secure data environment set up for research purposes and is fed by the electronic patient record that the 5 hospitals that are part of the Barts Health complex does. And those are available for project users having put in an application to our data access committee, and where there are public commentators saying, yep, that use of data is fine by us, we're okay with what you're doing with it. And that's a continuous dialogue which keeps us going. What's in that data platform? Well, as I say, it's mainly data from our Oracle Millennium EPR system. But as you probably saw on the other slide, there's a way of feeding data from other sources into that platform. We have 3.3 million patient records in there. And a lot of that data is in SNOMED, but obviously other forms as well, numerical data, ICD-10 codes, and so on. And if you're interested, our pipeline for creating that is publicly set out in GitHub, and it's a dynamic and rapidly changing story, and where I guess the next thing we're beginning to see is that we're sharing those data, and at least the metadata around those, in national repositories of data. And here's an example of something we've done where we show all of our data assets in the HDR UK phenotype library. And obviously, I'm pleased to be able to tell you that those are listed both as SNOMED assets and obviously other assets as well. But you can begin to see how SNOMED holds our clinical data assets as computable biomedical knowledge, that CBK that I had in my first slide, and holds the ability to do computational health by ordinary citizens, by children, going back to Kim's comment that children can't get into this stuff, I think that's beginning to change dramatically. Here's an example of something we practically do. So we've been linking genomes from South Asians living in East London, and about 30% of the population come originally from South Asia. We link their genomes, which are found by volunteering people on the high street, in the mosques, in the supermarkets, and so on, to volunteer both their blood or their saliva and their EHR assets in their GP and hospital records. We put those together and make new discovery using those data, and find fantastic ways into improving public health by the use of data and our platform. And so finally, I would say, look, all of this is almost ready to work. That revolution really is there. It is palpable. But none of it makes sense to humans if we just focus on the data. We have to find ways of including the things that make humans happy. So I put deliberately arts at the top of this little slide, because the things that really make society work are painting, poetry, literature, the Scarlet Pimpernel of our world. Obviously, the science live underneath that. And somewhere in all of this is artificial intelligence, which begins to glue all of this together and make assets that everybody can use at scale to make actionable health a real event. Thank you very much.
Love that. I could have continued to, I started to reflect on that, then realized I needed to come on stage to keep this going. That's such a great way to tie in the work that's done, the direction we're going, and the importance of it, Charles. So looking forward to bringing you back on screen shortly, but we're going to continue, I guess, around the world and in different parts of the international standards community to add some more flavors. So thank you so much. We'll see you in a minute. There we go. So next up in this session, looking forward to bringing on Herko, the one and only Herko. These people go by first names in this community. So it's great to see you, Herko. Keen to learn, hear a little bit more about the latest on the GDHP side and just generally data in Europe. And so we'll bring your slides up on screen too, and hopefully you'll be able to drive that, but I'm here if there's any hiccups. So over to you, sir.
So thank you, and thank you for having me here. I think I'm the last speaker, so I think with all that has been said by everyone and the people you've already had today, what's left there to say? So I hope I can provide some insight. So I am Herko Coomans. I work for the Dutch Ministry of Health, Welfare and Sport, where I am the International Digital Health Coordinator. And I'm trying to bring everything together from connecting the global with the local, because I think that's a nice thread through this whole day. So first, I am here representing the Global Digital Health Partnership, which is a group of national digital health authorities that work together to streamline and to align their digital health policies on topics such as cybersecurity and interoperability and digital health literacy and other topics that each of us are struggling with to make policies on that are effective and are useful. And as a group of 41 countries and the WHO, we sort of combine our knowledge and we pool our resources in order to do that. And one of the great examples, I think, that has been mentioned a few times already here, that does connect the global with the local, is the International Patient Summary. And why is that an interesting topic for the Global Digital Health Partnership? And that is because in 2021, the G7 asked the GDHP to advance or to accelerate the adoption of the International Patient Summary. You may remember we were in a pandemic at the time, and everyone was looking for global solutions. And so now we have, with a lot of organizations that are running international health data exchange programs, such as the World Health Organization, the European Commission with the European Health Data Space that Grahame just alluded to accelerate the development and the adoption of this set of standards. I'm not going to go deep into what the IPS really is, but I wanted to show you that on a section level what it contains, and you will recognize everywhere these elements. And that's not such a that's not really weird, because this is the general and generic data set that is used in as many clinical settings as we can use. So this is data that any doctor in any setting would like to know as much of to begin with. And this is what the global community has come up with as these are required and recommended sections. So these are problems and allergies and patient information and alerts and, of course, the medication summary. So this is what the IPS is, and it's being used in many global settings already. And the GDHP has worked with, for instance, the Saudi Arabian government to help implement the IPS for the Hajj, the annual pilgrimage to Mecca, where they issued 250,000 patient summary documents in a pilot with 4 countries, with Indonesia, with Malaysia, Oman, and Saudi Arabia, and got them to have these patient summary documents at the point of care in Saudi Arabia for 250,000 pilgrims. This was a pilot of a first version of this exchange, and it was done in only 7 months. And we first discussed this in Australia during the MedInfo conference. So that's how these things can start rolling. Grahame also talked about the European Health Data Space, which is a GDPR-like regulation. So it's law in the 27 EU countries that has the European Patient Summary, which of course has similar elements. That's not a coincidence, because the IPS comes from the original European Patient Summary that was developed by the 27 countries and now is becoming more global. There are subtle differences though, and that is becoming more and more not a problem, but an issue that we need to address. So in Europe, every country is now implementing the European Patient Summary because it is required by law to exchange patient summary data through that. We have a system of national, we call them contact points. These are national nodes that do the translation and the collection of the data, and they send it to another node in that network so that they can present the data in the language of the healthcare professional that would need to know this data. So this, of course, is the EHDS has just been approved, and it will go into effect in less than 2 years. And then there's a staged and staggered planning that it will go into effect by 2031, which includes EHR certification and many more requirements, not just for primary use of health data, so for provision of care, but also for research, innovation, and secondary use of health data. So this is at the European level, where we connect the global IPS to the European Patient Summary. This is one that I stole from my Australian friends. This is the AU core and the AU patient summary compared to the IPS and the IPA, International Patient Access Standard. And you can see here there's lots of overlap there as well. And we have a similar table for the Dutch situation, where we also compared it to the United States Blue Button Initiative. Who remembers that back in the day? And our Dutch core is the BGZ. It's our Dutch core data set for interoperability that we are also implementing right now. And we are aligning that now with the European Patient Summary, because again, there are subtle differences. And I think these subtle differences make all the difference in the implementation, because what we need is that we have locally relevant standards and usage of these standards, but that they are compatible and interoperable, of course, with their international versions. So when we say that we want to use international standards, then the real question here is what makes it an international standard, and where are we okay with deviating from that standard to make it locally relevant and usable. So that's why the Joint Initiative Council is also looking at a more coordinated development of the IPS, because there's national and regional implementations like in Australia and in the Netherlands and then in Europe. And then there are these governance bodies that coordinate some of these activities that are part of the IPS, because the IPS is a set of standards that come from HL7, from IEG, from SNOMED, from ISO, and maybe in the near future also WHO. These are reflected then also in SEN and ISO norms, which is different from just a standard. So we do need more of a global coordination effort in this, and I think that GDHP can play a big role in that. I wanted to end though with this man. Part of my job is that I travel around the globe as well as Grahame, and I try to follow him around every now and again. I'm still a bit miffed that he didn't reach out to meet with us here in Amsterdam with the ministry though. But this man I met at South by Southwest in Austin in Texas a few years ago, and this is John Cohn. He is an IEEE fellow, and he led the IBM in the Internet of Things lab that they had or still have. And he is, well, you can see he is sort of like the quintessential nerd. One of the things that he said really resonated with me, and he said that we are currently at a crossroads. It's either we let technology shape society, which is what we're seeing a lot of right now with the race for AI and how it will redesign our society and the way we vote for our democratic representatives, or how we transport ourselves from one end to the other end. So there's many things where technology is starting to shape society, and he says, but we also want society to shape technology, and that is why we are here, because we want to use technology that makes us more human, because that's what we feel that we're doing. And he said the way we do this, that we have society shape technology, is through standards. So our work that we do every day while we get up in the morning is to help create a technology that makes us more human. And what can be more in that space than in the health and technology and data space? Because standards in all their forms, because rules and regulations are also standards, they codify our societal values into machine-readable rules so that they can comply with those values. And these values are things like autonomy and equality and freedom and democracy. And they say something about when is it good enough in the sense of when are we secure enough, but also how do we translate human dignity, which is a very human value, into the rules for how machines will treat us and how they interact with us. What kind of decisions do we need to delegate to algorithms, and what kind of decisions do we feel that we as humans need to be able to make for ourselves? What is our autonomy here? And this is what we are doing day in and day out. So we translate these values, which I feel that we're not doing explicitly enough maybe, but we translate these into how we build our fire profiles, how we create our new ref sets in SNOMED, and all these other things. So this is why I get up in this morning. Well, it wasn't that much earlier than normal, but this is why I get up and get out of bed. And I hope that we can all work on creating these standards built on these human values, so that the technology that we use enable us to be more human and less of a slave to the machines. So thank you.
Love it. Great message to leave on, Herko, as always. And love striving towards that point of society shaping technology, as you pointed out too. I'm going to bring on all of the participants on for a bit of a discussion for us to close out this session. So thank you for the presentation. And we bring on all of the participants, including Graham, Rachel, Herko, and Charles, who we all know on a first-name basis, as was pointed out in the chat too, the digital health standards icons globally. So, I actually wanted to go back to you, Graham, actually, because earlier in the summit, earlier in this symposium, we were reflecting on, I guess, what makes Sparked different or unique, and I was drawn to my attention that back at the HL7 AU Trans Tasman Symposium earlier this year, you mentioned that Sparked is the most active accelerator in the world that you've seen. So I'd love to get a little, and you did touch on this a little bit too in your opening comments, but I'd love to get a little bit more context and reflection from you, perhaps, on why this is the case, and open to others on the panel too. But why is this the case, and what's, I guess, unique or different about this Sparked initiative?
Well, it's a confluence of wants and needs, really. But I want to acknowledge the department's leadership in choosing to pursue their interoperability agenda through the community. I encourage departments all around the world to make that choice for various reasons, but they all find it difficult. And so I want to acknowledge that. I want to acknowledge CSRO and Kate's hard work and creating this and getting it going and providing the drive and the energy. And then there's the rest of us who were ready and waiting for something like Spark that would let us actually do work together. Whenever I talk about the fact that what we're doing here is producing public treasure, that we're all better off because we all have the treasure. And we would be poorer if only some of us had it. And I think that we've endorsed that vision. And in terms of what's different, it's only different by degree. It's not special. Everywhere I go, countries are like, you got to tell us how we're special, how we're doing extra special work to overcome our extra special difficulties. And we did have some extra special difficulties, but they're only a matter of degree. Everywhere I go, it's basically the same theme. But it's come together, so let's keep it going. Yeah,
100%. I'm all for that. Open to others in the panel too, who might have some comments there. I saw Herko, you unmuted. Not sure if you have a comment on that particular one specifically, or you're just getting ready to chat.
I think what I see reflected in the way that Sparked is being run is that we are now getting to this point where our maturity in how we deal with this starts to demand that we take this very seriously and not just sort of. A lot of this has been very experimental in a way, in that we didn't really commit to it fully. And I think this is what we now see, is this inflection point of fully, with the whole ecosystem committing to these sets of standards. So it is a sort of a convergence that we're seeing. It is that we see these standards are being codified in national legislation. If you look at the amount of investment that is being put in digital health ecosystems and in digital health systems reform, there's a lot of resources that are being structurally put into this space right now. So I think Sparked is a really good example of taking this seriously and just building it into the core of the health system instead of something that is added to an existing health system.
Yes, Charles.
So I want to big up actually CSIRO, I think, in the way that some of the words in the chat are going. CSIRO is a remarkable organization, and the people I meet within the healthcare division is Kate, Mike Lawley, and lots and lots of others. They're remarkable, first of all, because they're super brainy, but they're also super accessible and super fun to work with. And so collaborating across, from Europe to Australia is a real thing. I've traveled to Australia to talk and meet and find ways of thinking together. And of course, Kate and her whole team come over here. And I think that's the thing that makes Spark super energetic. And it's astonishing, really, that a public organization funded by government works as well as it does. I don't think there are quite the equivalents in the UK of sort of openness and creativity and creating commercial assets like the terminology server that so many people now use across the globe. These are fantastic things.
Very well said. Oh, Rachel, yes.
I could just come in. I think there are two things for me. One, this is the future leadership that you need in health systems. We're seeing leaders here who've got the right culture, the right environment, they're showing how to lead to the future. The second thing for me actually comes back to Herko's final point. The human elements are part of Sparked. And what we're seeing here is it's for humans, it includes humans. One of my favorite books is Designing Freedom, written back in the 60s about how technology should enable humans to be freer and lead a better life. And what I'm seeing within, this whole program is a human focus, right? Humans before technology. You're considering the users, the implementers, the citizens. That's really special and unique. Interoperability here and data here is not just about the technicalities, it's about humans and the human impact. That's really different.
100%. Look, it would be remiss of me not to take this opportunity to ask you wise individuals a question that's kind of, hot and on topic at the moment, because, for years we've been working on trying to codify or ensure a language to take the things that humans do within a healthcare setting in a format that's consistent for the machines to be able to ingest and do clever things with, and we can then do things with it. And that's in my uneducated and rudimentary understanding of the reason why we have standards and coding and everything, to be able to input and do useful things with the data. But, and I'm being a bit facetious here, but work with me here. We've got AI now. We've got large language models, and it magically does this kind of stuff for us. So has all of this work been in vain, or isn't the AI the silver bullet to all of this? I'm serving that up for an opportunity for what I think I know might be the answer, but I'd love to get your perspectives on that, but in fairness, I think a lot of people might be looking at that and think, well, technology moves fast. Is what we're doing still right? Like, what's your take on, I guess, the rapid pace of the power of large language models and AI? And Grahame, I did hear you mention this at one of the events recently, the HL7 one, but I'm sure everyone's got a take on it too.
Shall I take that? Because having been the advisor to the UK government on the AI Council, actually it's the polar opposite. Standards become more important, right? Because AI is what it eats. And, if you fail to record things, then the AI will just fill in the gaps. Yeah. What you absolutely need is to know that you have the full and right data set to feed the AI, and it's got to be complete. You have to define that data set. You have to define that interoperability. So actually, in the work we've done, and actually what's come out of the AI summit in Paris and is going into the next summit in India, is the fact that data and data standards are actually more important.
Right on.
From my perspective, the challenge is, we don't know how far AI is going to go in terms of changing the basis of what Rachel talked about long term. Certainly where we are now, but the thing that stands out for me is however far we think LLMs are going to go, health will be one of the hardest places for it to apply and reliably, because if you're doing business and you lose 0.1% of your customer base because AI mistreated them, whatever. Health doesn't work that way. You have to get it right, and you have to prove that you got it right. And so we will be the slowest to really leverage AI in that regard. And we will mainly focus on leveraging AI for system efficiency, process-based augmentation, and that you need access to the system, and that means interoperability standards. For me, it's just going to wind everything up by orders of magnitude.
I completely agree, Graham. That's absolutely it. And I think the other thought is it is only part of an enormous ecosystem. And I think one of the risks, in my view, that I see all the time is people assuming that AI will sort of, if you like, solve everything. And that's so clearly not the case. And because of that, the issues that I talked a bit about, which is how do you get clinical professionals to use and record data really well, is a massive intellectual challenge, I think, because turning what's in your head into something you write down, which is substantially true and computable, is really hard to do.
I would like to add a different note, though, because in general, I very much agree with everything that's been said. A lot of the work that clinicians and healthcare professionals are currently doing would be obsolete if we are able to create a better interface between what they're doing and the systems that are supporting them. And a lot of the work that is being done to create the better data that we need for everything, including training AI, as Rachel very rightly said, is now being done by people who have other things to do, basically, and better things to do, and better ways to spend their time. So I do think that while we may be the slowest in leveraging the full power of AI, in having AI run part of the way we do healthcare and how we treat patients, I think there's a huge untapped potential there that we really need to leverage in freeing up a lot of the time and mental space, the headspace of the already overburdened healthcare professionals. And the only way we can do that is by really applying AI very fast to that. We don't need all the clinical data for that. It's mostly process up and healthcare pathway design that we need to improve and leverage AI in that. And if you look at the speed with which AI is developing, I don't know if you've seen the new Google VO3 models that are basically creating movies from scripts from prompts just like that, and that are actually quite good looking already. The power that is there is going is expanding so rapidly that the lagging isn't because healthcare is complex. I think it's because the technologies that we've used and that we've implemented are unnecessarily complex, that make it hard to get into healthcare the way we want. So I think the benefit here is in the interface, and we need to focus way more on that.
Great points. I want to try and cram in as many questions and discussion points as possible while I've got you wonderful humans with me here, because a great question's been asked by Peter O'Halloran from the Australian Digital Health Agency. To Graham's point earlier, should our digital health standards become digital public goods to recognise the value for everyone globally arising from the use of these open standards? So I'm not sure if anyone's got some perspectives. I guess the digital public goods being full open source, is that I should have Googled before I started talking, but that's my understanding of that digital public goods. Walk me through. Does anyone have any thoughts on is this pipe dream reality, something we should work towards, and what does that look like?
So fire is already recognised as a digital public good formally.
Yeah.
And that reflects its wide applicability, particularly in the developing world, the lower middle income countries. There's some actual technical requirements that are kind of tricky for a standard around a digital public good, and we sort of need an ongoing engagement with the administration around digital public goods as what makes something suitable for digital public good, because a lot of our standards would actually not easily qualify. And even though it's they should, from my point of view, but it also calls into question some of how we develop standards, because to be called a digital public good implies an ongoing commitment to public outcomes that not all standards are structurally, process-wise suited to deliver on. And so it's kind of like an ongoing discussion between the digital public goods community and the standards community over what makes a good outcome. But for me, standards are the best example of a digital public good, and we should look after them accordingly.
Absolutely. And I put through there, Graham, openEHR again is an open standard. We've been looking at how we declare it as a digital public good. From my perspective, though, how do you support and maintain standards as a digital public good if you're going to make more standards, freely available, open source? I think there is a bigger debate, and I know, Herko, you've been involved in some of this, about how we maintain and fund standards long-term globally. And I think that is the big question it begs for me, because some of the standards that aren't a digital public good at the moment may not be sustainable in today's world without the business model they've got. So that's one elephant in the room.
No, I fully agree. Part of this is that if we are building our digital health ecosystems or even our healthcare systems on these standards, and if we're formally legislating the use of these standards, then we need to ensure that they will be available for the next 20, 40, 60 years to come, and that that they will be maintained, and that there will be quality control, but also that there is a public element to the governance of these standards, because many countries, including Australia and the Netherlands, have a formalized process to determine the interoperability need. That also includes public consultations, and then sort of funnels into this set of requirements that are nationally mandated. And sometimes now in Europe, we're building this at the regional level in 27 countries that will then radiate out to any country or organization that wants to do business in Europe. So it doesn't just extend to the way that these standards are developed, or if they address the right problems, because I think these are very important elements, but it also extends to the governance model and the role of public organizations in that governance, which we're not there yet. I mean, there's no global representation that is sort of like the usual candidate for this. We used to think it was the WHO. Currently, we don't think that it could be the WHO because it's not that global representation anymore. Some say it might be the GDHP, but it's not an organization, so it doesn't have that formal role anywhere, and I'm not sure if it should. So this could be a really interesting ongoing discussion for the next, not too long, I hope.
Yeah.
I think the other thing that we're sort of dancing around without actually saying the words, but a digital public good, a standard, cannot necessarily be free, if that's what's being implied by digital public good. Standards, as each of the speakers has said, have to be maintained, looked after, developed, adding, in my world of terminology, it's adding new concepts, modeling those. All of that has a cost because they're human beings doing it. I don't think it can be, you can't generate terminology just using a computational tool. Although there's vast advance on that, but it all has to be managed and governed by a license system and contributions from either people or countries or whatever, which, as you know, is the model around SNOMED. So I think the danger is that if one gives things that label, then there's an assumption that, like the assumption that open source is free. It is not. Everybody knows that in reality, you have to pay and fund those kind of initiatives and so on. And so I think the debate needs to become, I don't know if sophisticated is the right word, but it needs to be explicit about what we actually mean.
Charles, I appreciate your final comments on that one there. I'm super conscious and respectful of all of you individuals' time and the insights that you've shared and new perspectives and thoughts that have added to this day throughout. We have hit time on this side, but I guess for attendees as well, they'll have to come along to future sessions. No doubt we'll be able to bring you all in to continue these conversations here as well. So Grahame, Charles, Herko, Rachel, I am super grateful for your time.
Thank you.
And as we wind out the Sparked Symposium, Kate, I know you have been actively participating in the chat there up here on stage with me at different times. How did you find today? It's a good rehearsal, and when you're ready to unmute, you can unmute on the platform and then give it another crack.
I forgot to unmute. There only had to be one person today that forgets to unmute, and I'm glad it's
we
me
nearly
at the end
got
of the day.
there, but I'm glad it was you.
My first question is, what is in your coffee all day? How have you maintained this energy for now 7 hours, 43 minutes and 22 seconds? Massive thank you to you, and I want what's in your coffee. People think I've got a lot of energy, but you just, no, I don't. Today has been, I've learned a lot today. It's been great hearing from all of our speakers, like right back to this morning with the Daniels and Steve and Abby, all the way through to finishing it. And really importantly, we wanted to round it out with the standards organisations this afternoon. So yeah, huge thank you to such a fantastic chat as well, and so much and so many comments in the chat. So we would love to know, do we do this again? What was your highlight of today?
So pop it in the Menti there. We've got the Menti code that you can use, and I'll pull up the QR code as well. Let me just hover it here, and you can scan that, or you can just enter it in. Thank you for those. We can see some of the individuals who were in the chat from the start right through to the end as well, and that's what makes, from my experience anyway, the Spark community so special and unique. And it's great to see some comments already coming through around the quality of the international speakers. Yeah, I like that we really lent into the whole virtual platform thing too, to be able to get those perspectives literally from around the world. So we'll let that continue to pile on through, and people can have a look at those answers as they continue, even if they're not on the screen there. Just use your phone or device to pull up the Menti. So it's great to see. It's good to hear that the content was good, and we'll let those continue to roll through. But it sounds like, Kate, that there's sorry, you go.
I was going to say there's been a lot of questions in the chat around will the videos be available? Will the presentations be available? Absolutely, yes. So anyone who is not following us on the Sparked LinkedIn, then please jump onto LinkedIn and follow us, and you'll see when the videos, the presentations, and more importantly, more of those demo videos from more of our amazing Sparked community are going to be made available.
Amazing. Look, I'm just looking at this. It's difficult to keep up with the chat now, but keep those comments coming through and feedback rolling. And no doubt we'll see members of the Spark community here in Australia and around the world. It sounds like Europe's the place to be in the coming weeks, Kate.
I think we'll be seeing you there, Pete.
Yeah.
I'm very much looking forward to Dev Days next week, where we get to talk about the amazing work of the Sparked community as part of the winter plenary session. So I'm really excited to be able to represent all of your amazing work there. Also, very excitingly, we've got one of our Sparked community, Dr. Talat, is actually going to be a keynote at Dev Days next week. So really importantly, bringing the clinical perspective around how standards can actually importantly support workflow and clinical practice. So I'm so pleased to see one of our own up there with a plenary next week at Dev Days. Can't finish this without reminding you that there are Sparked events coming up in the future as well. So please, as I said, either for those that are new to Spark today, that have now drunk the Kool-Aid, we are not a cult. But for those who are really keen to get involved, please register. We have upcoming face-to-face meetings in Sydney at the end of July. Importantly, the next HL7 Australia Connect-a-thon is going to be in Brisbane in September. So for those developers who are not yet actively coming along and testing as well, please make sure you sign up and come along to the next Connect-a-thon.
Amazing. Well, I think we can leave it there. Kate, great message to leave out on, and hopefully looking forward to connect with people soon. There's still some what I like too is that we're going to end on a few videos to really showcase some more members in the community too. So keep those comments and messages coming through in the Menti, and I'm sure there'll be feedback and everything requested then. Until next time, everyone, thanks so much for your time.
Thanks, Pete.
So excited today that we're holding a Trans-Tasman Symposium.
I think fire is the way of the future.
Here in Sparked, we're really looking for connections.
It's a great opportunity to show what we're doing and to integrate with other people.
Community is so important. I love what's happening in the health space.
If we can all come together as a community, we've got a better chance of creating a standard that works for everyone.
We actually want to embrace these global standards.
Standards underwrite everything.
It's a vibrant community, very, very smart people.
I really enjoyed participating in these Connect-a-thons events.
It really is about supporting the clinicians to do better with their patients.
I think we just keep learning, keep improving, keep moving forward. Get involved.
Get involved.
Get involved.
Get involved.
Get involved. Come to the meetings.
The discussions have never been more vibrant. This is what we need to see to get standards out there in use, making a difference for healthcare.
Big change. It doesn't come easily. It starts with big ideas. It listens to experience, builds one community through collaboration and transparency, and ignites revolutions that change the way we share and use data for the better. Sparked, Australia's Fire Accelerator program. Because good data means better health for all Australians.